Hello and welcome to this ACARE LevelUp, where we're going to discuss HAE with normal C1 inhibitor, a very challenging and difficult topic, and I'm sure we will all learn something tonight. Before we start, I want to take a minute to pay tribute to Marcus Maurer and to send condolences from his friends and colleagues in Australia to his family and colleagues in Germany. We've all been greatly touched by his passing. Marcus was a leader, a teacher, a researcher, and an innovator. And this LevelUp program was his baby. He's greatly missed, and we all remember him very fondly and with much sadness. My name's Connie Catelaris, and I work in Sydney, Australia. Tonight, we have a very distinguished faculty. We will hear three presentations. Marc Riedl, because of the time difference, won't join us online, but his presentation will be played to us. But joining us in person, we have Professor Anastasios Germenis from Greece, and he will be talking about the genetics. And we have Professor Anete Grumach from Brazil, from Sao Paulo, and she will take us through the clinical manifestations. So I promise you a wonderful seminar. The learning objectives tonight include increasing our understanding of the varied clinical presentations of HAE with normal C1 inhibitor, and to learn about the complex genetics of this condition. We will move shortly to Marc's presentation, followed by Anete and Anastasios, and we hope to have a few minutes at the end for question and answer and discussion. Tonight, we are joined by many people from all around the world. We have 62 countries participating and around 180 registrants. Just to emphasize the fact that we are a global family, we can see here that we have representatives from all of Europe, from Asia, India, the Middle East, from North and South America, and from my own country, Australia. Just to remind you that CME accreditation is available, but in order to receive your CME points, you must complete the feedback form. Here is the QR code, and if you can complete this at the end of the webinar in order to receive your points. Leave your comments and questions in the question and answer box or in the chat, and we will endeavour to answer them for you. Just to remind you that we do have a LevelUp newsletter, and you are welcome to subscribe. And similarly, you may subscribe and stay connected using all the socials. So without further ado, we will hear Marc's presentation.
Hi, everyone. I'm Dr. Marc Riedl from the University of California, San Diego, where I'm a professor of medicine and also the clinical director of the US HAEA Angioedema Center. I'm very glad to join you for this webinar today. I'm sorry I'm not able to attend in person, but it's certainly my honor to give this brief presentation on HAE with normal C1 inhibitor. And my charge is to sort of set the stage. I'm going to talk about the history, the meaning, and briefly touch on the types of HAE with normal C1 inhibitor. Then, of course, you're going to hear more from my colleagues, more details about these specific subtypes. These are my disclosures. And so just to set the stage, I want to remind everyone we have numerous causes of angioedema. This is the differential diagnosis that we as clinicians go through when we see patients with recurrent angioedema symptoms. On the left side are those that are generally considered mast cell mediated and very common, in fact, much more common in clinical practice than those on the right side of the slide here. But of course, we're going to focus on the right side, these types of angioedema that are thought to be non-mast cell mediated or non-histaminergic. There are numerous types, as you see listed there, and we're going to focus mostly on HAE with normal C1 inhibitor, and you can see the various subtypes that we'll touch on defined by the genetics, but also recognizing there are unknown types of HAE with normal C1 inhibitor, and also at the bottom there, idiopathic angioedema, of which a subset is likely to be non-mast cell mediated. And I will admit at the very beginning here, it's often very difficult to distinguish between HAE with normal C1 inhibitor and so-called idiopathic non-histaminergic forms of angioedema. And just a reminder that clinically, these types of angioedema that we're discussing, HAE with normal C1 inhibitor, do present with a different clinical presentation from the more common mast cell mediated angioedema. This table is a bit simplistic, but in clinical practice, these are the questions it's important for us to ask about. And you see in that right column, the kinin mediated or non-mast cell mediated angioedema. These symptoms tend to be longer in duration. They take hours to progress and typically will last for days if not treated, as opposed to mast cell mediated angioedema, which comes on much more quickly and generally has a shorter duration of the episodes. Non-mast cell mediated angioedema, bradykinin mediated HAE with normal C1 inhibitor, it usually presents with the absence of urticaria and pruritus. And you're going to hear a little bit later about one subtype of HAE with normal C1 inhibitor that might be breaking that rule, but generally speaking, people with HAE of all types don't present with hives or itching. And then, of course, response to therapy is very important to ask about and observe in clinical practice. Hereditary angioedema, at least as far as we know of all types, does not respond well to mast cell targeted therapies. Response to antihistamines, response to corticosteroids and epinephrine. And on the right is a nice table from a publication by Jonathan Bernstein and colleagues, really showing this trajectory or the clinical course of histamine-mediated angioedema with that quick early spike and resolution versus ACE inhibitor or hereditary angioedema, which has this, again, more prolonged or protracted course. So important to recognize these different clinical characteristics of HAE as a non-mast cell mediated and usually we think bradykinin mediated condition. So what do we know about HAE pathophysiology? Well, this is not the topic for today, but this is HAE due to C1 inhibitor deficiency and decades of work to show that this type 1 and type 2 HAE is due to C1 inhibitor deficiency. If you're missing C1 inhibitor, you lack the inhibitory properties that keep factor 12A and kallikrein in check, and you make too much bradykinin. So a mechanism that's very well worked out for type 1 and type 2 HAE. And we think we understand type 1 and type 2 HAE quite well. We think we know how to test for it, as you see here, looking at C4 levels, C1 inhibitor antigen, and functional tests that will fairly reliably identify C1 inhibitor deficiency. And of course, a lot of work over the years showing that this is due to mutations in SERPING1, and many mutations. You can see we're probably well over 900 now mutations that can cause C1 inhibitor deficiency. But for better or worse, HAE turns out to be not quite that straightforward or simple. And so we think we understand type 1 and type 2, but then the history is these reports come along about almost 25 years ago in 2000, two research groups almost simultaneously publishing these descriptions of HAE with normal C1 inhibitors. So Conrad Bork in Germany, Karen Binkley and her group, also in Canada and the US, describing these patient populations that have all the signs and symptoms of hereditary angioedema that we just discussed, but have normal C1 inhibitor level and function. And so for the last 20 plus years, we've been trying to figure out what is the underpinnings, what is the cause of this form of angioedema. And so you see that added here to the table, and it's in the guidelines now that recognizing this exists. We don't have a great understanding of it in some cases, but it is a clinical entity that we see in practice and presents with real clinical challenges given our routine lab tests are normal. Our complement testing is normal in these particular individuals. So what's happened in recent years? Well, we have made progress, and you're going to hear more details about this shortly, but I've just sort of given you a summary here. We've discovered collectively as a scientific community some variants, genetic variants that are associated with HAE normal C1 inhibitor, running in families in pedigrees that have these signs and symptoms of HAE, but normal laboratory results. And I'm not going to go through these in detail. I'll leave that to my colleagues, but recognize that we're up to 8 now, 8 specific mutations or variants that seem to be associated with HAE normal C1 inhibitor. Some are understood better than others, but this is the current list. We also have to recognize, though, that there are families, there are patients that have all the signs and symptoms of HAE, but have normal complement tests and do not have these described mutations to date. So this is the so-called HAE unknown, and studies, including those by Conrad Bork's group, which have described many of these patients or families, recognize that a substantial portion of patients do not have any of these genetic findings, despite a very strong or a clinical history consistent with HAE normal C1 inhibitor. And so we continue to look for genetic markers. Again, you see the 8 that we know of listed here, the last 2, HAE CPN1 and HAE DAB2IP, having been recently described within the past year. Unfortunately, because we still have this population of HAE unknown, there's been a lot of ongoing work for other biomarkers, other biochemical markers that might suggest dysregulation of either the contact system or other vasoactive mediators that control endothelial leakage and might predispose to recurrent angioedema. And you can see this pinwheel of various laboratories studying different biomarkers that may be useful. In recent years, it may be increasingly possible to measure bradykinin levels themselves, which has been elusive or very difficult technically in the past. Kallikrein activity, ELISA assays to look at kinin fragments and so forth. So these have not been useful yet in clinical practice. There's still validation work going on, but a lot happening in the biomarker world to help supplement these genetic markers, and that list, of course, continues to slowly grow. Now, because we lack a true validated biomarker or biochemical marker, and because we struggle with families or individuals who do not have these described mutations, there has been consensus documents outlining clinical criteria for HAE with normal C1 inhibitor. This is taken from a New England Journal of Medicine review a few years back, but based on really an expert consensus that's almost, is actually over a decade old now. And these criteria include recurrent angioedema without hives, without use of a medication known to cause angioedema, normal C4, C1 inhibitor level and function, a documented lack of response to high-dose antihistamines, and I'll come back to that in a second, or one of these mutations which shows and one of these mutations that's been associated with HAE normal C1 inhibitor, or alternatively, a strong family history of angioedema. And then you can see supportive data, the lack of response to mast cell targeted therapies, a clear history of a reproducible and durable response to a bradykinin targeted medication, and then certainly with predominantly abdominal symptoms, we like to see documentation consistent with angioedema of the GI tract. There's mention of emerging biomarkers, but as I said, these still require some work to validate and show that these are sensitive and specific in these patient populations. So we have genetic markers, we have ongoing scientific work for biomarkers, we have some diagnostic criteria. Unfortunately, we still, I think, have considerable limitations in diagnosing HAE with normal C1 inhibitor. I've listed a few of those there, including what I've already noted, that there are a substantial number of patients where this diagnosis is suspected but don't have identified associated mutations. We then lean on the family history, but recognize that family history is a very weak criteria, meaning that there are limitations such as some people don't know their family history. They could be adopted. They might not know their parents' medical history. They might not know any of their family history, there's also the concept of variable penetrance with genetic changes. So you could, and this has been documented in factor 12 patients that are males, that they may not express angioedema, but still carry a genetic issue that may lead to angioedema in subsequent generations. And finally, de novo mutations. What's to say that an individual with no family history could not have a de novo mutation, perhaps an undiscovered or unknown mutation that would lead to a genetic form of angioedema? We certainly see that in type 1 and type 2 HAE, where this de novo phenomenon is well documented. And lastly, part of our clinical criteria really rely on response to targeted therapies. And so defining what is a response, what's the right medications to give, what's the dose of medications, how long do you give those medicines in order to determine whether there's a clear clinical response. There's difficulty in defining that and all the community agreeing on all of those things. And so I would just say we still have work to do to really feel comfortable that we are appropriately diagnosing and not missing patients with HAE normal C1 inhibitor. I would also say that there is, again, can be difficulty in defining what's hereditary angioedema and what's idiopathic non-histaminergic angioedema. And right now, that really depends mostly on the family history, which, as I've outlined right here, is not a particularly reliable criteria. So in my view, and my colleagues may disagree, it's difficult to be terribly dogmatic about how we define HAE with normal C1 inhibitor when there are likely to be so many unknown genetic factors, and these criteria that I've outlined for you have certain limitations. Lastly, one of the questions is, what's the prevalence of this condition? And I think this is a very difficult question to answer because, as I just noted, it's sometimes hard to define specific criteria for HAE normal C1 inhibitor. There has been some various studies in countries, including some European countries. I've just noted here a US survey that was done recently using surveys of patients who treat, physicians who treat HAE and cross-reference with some prescribing data. We came up with an estimated prevalence of about 1 in 250,000 people. And it's interesting, here's a study that was done, a survey of international angioedema centers, 30 of them, in fact, across the globe. And you can see the variability in the percentage of patients, of overall HAE patients, that were diagnosed with HAE normal C1 inhibitor, ranging from 2% at centers in the Netherlands up to 44% to centers in Austria. Overall, across the centers, it was about a quarter of the HAE population that are suspected to have HAE normal C1 inhibitor. And so that, again, arrives at around this prevalence of perhaps 1 in 200,000 or so, if you sort of look at the prevalence of type 1 and type 2 HAE and extrapolate from that. But again, the difficulty is, are people using the same criteria, the same methodology, the same diagnostics or clinical criteria to make the diagnosis? And I think the answer is we are seeing some variability of that across international centers. So there are efforts to try to tighten this up a bit. Additional resources I've listed here. This algorithm on the left is a nice review paper by Connie Katelaris and colleagues published last year. I think it gives us a good flow diagram in the clinical space to sort of think about how to make this diagnosis, either with genetic testing, as you see at the bottom right, or perhaps using response to therapy as a guide to get us to that point as well. And there is a forthcoming publication from an international expert panel consensus meeting that was held on this topic about a year ago. And so that paper is in the very final stages of before submission for publication. It has been an interesting process because, again, many experts and many points of view, but I think we have come to a consensus that will be very helpful ultimately to help guide us in the clinical space, and some general agreement about how to approach this diagnosis, both with genetic testing and also using our clinical acumen, following the patient over time with our management plans. So with that, I'll thank you for your attention. I appreciate the opportunity to speak with you. Enjoy the rest of the webinar.
Hello. Now I'm Anete from Brazil, from Centro Universitário FMABC, and I will share my my screen with you. Okay, I assume that you can see me. We are talking about new variants and the clinical differences among AJE normal C1. Here, my disclosures. Sorry, I am having some technical issues here. Oh my God. Okay. My disclosures. And I will begin with the definition of AJE normal with normal C1 inhibitor. These definitions with recurrent angioedema affecting one or more organs, no use, which we will discuss further, hormonal influence, positive family history, which was Marc, and normal C4 and C1 inhibitor. We had the description of several new mutations, and it was reported by Marc, so I won't repeat. So we have the opportunity to discuss these points. But I will focus on the last two new variants associated with AJE and normal C1 inhibitor. Going back to the, I would say, old or last AJE with normal C1 inhibitor descriptions, we have the first one, which is the factor 12 mutation. So we know that there is a predominance in females, and as we see here, we can see that also plasminogen plasminogen variants are associated with female sex as well. But the other descriptions include females, but they represent only few families. So it's difficult to establish that there is always a male predominance. The family history is present in factor 12 from 67 to 90%. We have experience in Brazil of a high number of patients with family history, but it's possible, as mentioned, that we don't find the family member who presented the disease, and it's also reported with plasminogen mutation. The age of onset is interesting because most of them develop a little bit later than patients with AJE and C1 inhibitor deficiency. We can see here that over 20 years or after the puberty are the main period where represent the main period where the onset of the disease occurs. Trigger factor first variant, but all variant, other trigger factors occur in other variants. And we can say about the main sites of edema that plasminogen, in plasminogen we have the tongue affected, but the others have variable presentation, and we will show the new variants, how they present to us. I will comment a little bit about angiopoietin 1. The patient, it's one family only. I have another family, but it's not published. And the patients present severe abdominal pain, and the other affected patients, they present mild symptoms. It's difficult to establish the clinical symptoms of these patients, considering that we have one family reported until now. One addition to this clinical picture is the appearance of bruising in these patients. The HAE with kininogen 1 also occurs later in life. We have triggering factors, including hormones like oral contraceptives and pregnancies, and it affects as it is affected in HAE with T1 inhibitor deficiency. We have facial edema, tongue, hand, and feet swellings and abdominal attacks. So these are pictures of prodromes that were described in patients with angiopoietin 1, but these patients present unknown mutations. So let's talk about the new variants. We have seen that we have hormones related in these patients. We have late onset comparing with HAE and C1 inhibitor deficiency. And recently it was described the variant in carboxypeptidase N. It's interesting because its activity is centered in the catabolism of bradykinin, in plasma bradykinin, and it could inactivate anaphylatoxins. And so we will see something about the history of carboxypeptidase. In 1986, a male with 65 years old was reported with the reduced activity, 21%, and recurrent angioedema. He presented recurrent angioedema for 11 years, and it was linked to allergy and asthma. And at this time, elevated histamine was observed during the attacks. And I will show you why I am presenting this case. In 2008, a female with carboxypeptidase deficiency and used ACE inhibitor and then developed angioedema after 2 years using ACE inhibitors. So we have this action, additional action, and we know that carboxypeptidase and can control over multiple mediators of inflammation, vascular permeability, chemoattraction, and leukocyte activation and trafficking. And finally, there is a report in mice that the carboxypeptidase could control or regulate vascular leakage. So recently, it was described the carboxypeptidase variant in 4 families. We have one family represented here. And the most interesting part is that the families presented urticaria. Besides peripheral angioedema, abdominal and laryngeal edema, they also present urticaria. I included here a kind of picture showing that most of them, there are 17 persons affected by the variant. We can see that it was present in almost all of them, and with late onset of the disease. We can see now, we talked about carboxypeptidase. Now we are changing to the last variant described, which is the DAB2IP, is human disabled homologue to interacting protein. And I like this picture because it shows the expression in the vascular endothelium. We can see here in this picture, and the action is a signal transduction, and we can prevent some interaction with this protein. Going on in this publication, which is very, very interesting, we can see here, without the action of this protein, the absence of control. How are the patients? It's one family described with 7 members affected. We can see here the genealogy of this family. And how is the clinical presentation? This is the idea, to compare the different clinical presentations among variants presented by AJE and normal C1. And we can see that this woman, this index patient, had abdominal edema above 5 years old and was misdiagnosed as appendicitis. She presented also edema affecting extremities, genitals, larynx, face, and of course, it was tried to treat as allergy with steroids, antihistamine with poor response. And you have seen that Marc showed that these patients present a poor response or no response to steroids and antihistamines. After that, the patient suffered tonsillectomy, tooth extraction, and she developed edema. But the most interesting thing is that she also presented urticaria, hives, itching, and after 2 days, more or less, she improved. In the following period, she developed endometriosis and used estrogens. And then the hormones made her worsen. And finally, she was treated with icatibant, and she improved after that. Let's see how the other members were affected. She has 3 siblings, and they presented also abdominal pain, vomiting very early in life, edema of genitals, and also urticaria rash, both of them. And we can see here, I prepare like a table showing the symptoms of the whole family, and you can see that most of them presented abdominal pain, some with face edema, genitals were affected, 2 of them laryngeal edema, but the urticaria, or at least the hives, were present in 5 out of 7 members of the family who were studied. So we have a different clinical picture in this group, the new group, and the response to Firazyr, to icatibant, was good in both patients. So my idea was to discuss the definition of AJE and normal C1 inhibitor, and this is the same mentioned by Marc. Is quite difficult to establish some points, but now we are adding to these variants wheals, hives, in these 2 last reports. The hormonal influence was not present in all the variants. There are some variants which other trigger factors are more important and identified. Positive is family history. I know that it was well described by Marc, the difficulties that we have. There is a recent publication by Marc showing that about 10% of the patients had mutation, and it was hard to get the family history. biomarkers are difficult to be established until now. And could we add another point in the response to icatibant, since we have these last variants which we tested with icatibant and the response was fine. So our final comments are that AJE, a normal C1 inhibitor, has been associated with different mutations, and 2 new mutations has been described, with the difficulty to add wheels to the clinical picture. The genealogy is relevant and necessary to confirm AJE and normal C1 inhibitor. We have these points raised by Marc, and actually some publications give support to this comment. As I mentioned, wheels have been associated with new variants, and I always repeat the experience of Professor Conrad Bork, which each AJE normal C1 type to be considered as a distinct disease entity, and you could see that it's quite difficult to establish all the clinical picture as similar or responsive to all the treatments. So thank you very much. And now Dr. Germenis will follow me. Thank you.
Hello, everyone. I'm Anastasios Germenis from Greece, and I'll speak to you about the usefulness of genetic testing in the diagnosis of hereditary angioedema with normal C1 inhibitor. My disclosures. As already presented by previous speakers, hereditary angioedema with normal C1 inhibitor accounts for a small percentage of the total hereditary angioedema cases. By the beginning of this year, genetic alterations in 6 genes had been found to be associated with the disease, namely the coagulation factor 12 gene, the plasminogen gene, the geopoietin-1 gene, the kininolate gene, the myofferlin gene, and the heparan sulfatic glycosamine 3-O-sulfotransferase 6 gene. These cases represent about 30% of the total hereditary angioedema with normal C1 inhibitor cases, while the rest are still of unknown etiology. The vast majority of cases with a known genetic etiology are due to alterations in the factor 12 gene, and to a lesser degree in the plasminogen gene. 4 F12 mutations have been identified as causative for hereditary angioedema with normal C1 inhibitor, and all are located in exon 9 of the gene. However, 95% of F12 hereditary angioedema are due to 2 missense mutations resulting in threonine to lysine or threonine to adenine substitution in position 328 of the protein. Similarly, a missense variant in the plasminogen gene is responsible for the plasminogen hereditary angioedema. All variants of the other genes associated with hereditary angioedema with normal C1 inhibitor have been detected in 1 or up to 5 families each. This also applies to the 2 new types of hereditary angioedema with normal C1 inhibitor reported these years and previously detailed by Dr. Grumach, namely the hereditary angioedema due to carboxypeptidase N deficiency and due to mutations in the human disabled homolog 2 interactin protein. All types of hereditary angioedema with normal C1 inhibitor are inherited with incomplete penetrance. With regard to the detection of new pathogenic variants in the same or other genes, this feature weakens the validity of family segregation as a criterion of pathogenicity. The elucidation of the genetic basis of hereditary angioedema with normal C1 inhibitor has revolutionized the research of angioedema, as it has shown that the contact system is not the only player in the pathophysiology of the disease. Certainly, the emergence of the role of endothelium will very soon reorient the management of the disease. From a clinical point of view, genotyping is extremely important for the diagnosis of hereditary angioedema with normal C1 inhibitor, as the variants associated with the disease are the only biomarkers available for this purpose, at least at the moment. Otherwise, the diagnosis of hereditary angioedema with normal C1 inhibitor is based in the exclusion of hereditary angioedema due to C1 inhibitor deficiency and on clinical and therapeutic criteria. However, the question that arises is, why should we submit a patient suspected to have hereditary angioedema with normal C1 inhibitor to genetic testing, since so far there is no specific treatment available for the disease? Practically the same drugs that are efficient in patients with hereditary angioedema due to C1 inhibitor deficiency are also effectively used in hereditary angioedema with normal C1 inhibitor. The main contribution of the genetic testing for hereditary angioedema with normal C1 inhibitor is to exclude the diagnosis its diagnosis from other types of angioedema with normal C1 inhibitor, including cases of mast cells-mediated angioedema and acquired angioedema. This is the main practical reason why the recent version of international guidelines for the management of angioedema recommend that patients who are suspected of having hereditary angioedema and have normal C1 inhibitor levels and functions should be evaluated for known mutations underlying hereditary angioedema with normal C1 inhibitor. However, detecting all mutations that have been shown to be associated with hereditary angioedema with normal C1 inhibitor is an expensive and time-consuming effort that is difficult to perform in a daily practice. To this end, specialized laboratories have developed and are pursuing cost-effective algorithms to eliminate the cost of the diagnosis of hereditary angioedema with normal C1 inhibitor. Such an algorithm is presented in the next slide. According to this algorithm, patients with suspected hereditary angioedema with normal C1 inhibitor are initially tested for the F12 mutation that is the most common among the identified variants responsible for the disease. Allelic discrimination assay, a multiplexed endpoint assay that detects variants of a single nucleic acid sequence, is proposed for this aim. This assay is accurate, inexpensive, and fast, and thus can be performed easily, even in patients without family history. Allelic discrimination could also be developed to simultaneously detect all other missense mutations that cause hereditary angioedema with normal C1 inhibitor. If the test for the T328K F12 mutation is negative, Sanger sequencing of exon 9 of F12 gene is recommended, and if this is also negative, detection of the missense mutations in other genes causing hereditary angioedema with normal C1 inhibitor is recommended with priority to plasminogen and angiopoietin-1 mutations. If mutations are not detected in these genes, the algorithm indicates that patients with a family history of the condition are more likely to have hereditary angioedema with normal C1 inhibitor presenting as unknown hereditary angioedema, while patients without a family history are more likely to have acquired angioedema. In conclusion, genetic testing for all currently known hereditary angioedema genes has low yield for hereditary angioedema with normal C1 inhibitor, but is necessary to precise clinical diagnosis. Even negative genetic results after comprehensive genetic testing can aid in interpretation of a clinical diagnosis. However, a recent study from the United States showed that less than half of the patients involved in the management of angioedema use the benefits of genetic testing in the differential diagnosis of hereditary angioedema with normal C1 inhibitor. It is likely that this is due to the fact that genetic testing is not usually carried out in laboratories specialized in the diagnosis of hereditary angioedema, with the result that next-generation sequencing is the most commonly used technology. An advantage of the use of next-generation sequencing is that beyond the well-documented variants causing hereditary angioedema with normal C1 inhibitor, other variants possibly associated with the disease could be detected. As you probably know, the proof of pathogenicity of such a variant is a complicated process. The American College of Medical Genetics and Genomics has developed a guidance for the interpretation of sequence variants about a decade ago. Briefly, according to these guidelines, variants are classified as pathogenic, likely pathogenic, uncertain significance, of uncertain significance, likely benign or benign, based on criteria using typical types of variant evidence, including population, computational, functional, segregation data, etc. The information provided by disease-specific databases on assertion about the clinical significance and phenotype relationship of variants is of utmost importance in regard with the curation of novel variants. Therefore, if a variant suspected to be associated with hereditary angioedema with normal C1 inhibitor is detected, it should be reported to a disease-specific database. Thus, the accumulated information will be available in the future to support the curation of this variant. Even variants that have been proved to be associated with the disease are recommended to be reported in order to enhance the validity of their classification. Family segregation studies are an additional feasible and extremely valuable effort that clinicians can make to enrich the information that accompany reporting of the mutation. Keep in mind, however, that the incomplete penetrance of the variants associated with hereditary angioedema with the normal C1 inhibitor does not justify family segregation studies for prognostic reasons, as it happens in hereditary angioedema due to C1 inhibitor deficiency. As far as the disease-specific databases are considered, the most reliable now is the ClinGen. ClinGen is a source funded by the National Institute of Health of the United States and is dedicated to creating a centralized resource that determines the clinical significance of genes and variants. The great advantage of ClinGen is that for the variants related to each genetic disease, it constitutes a curation expert panel aiming to modify the criteria of pathogenicity proposed by the American College of Medical Genetics and adapt them to singularities presented by the individual genes. Such a variant curation expert panel exists for hereditary angioedema and up to now is focused to the curation of SERPING1 genes. After that, the panel is scheduled to develop pathogenicity classification rules to curate variants in genes responsible for hereditary angioedema with normal C1 deficiency. Thereafter, variant interpretation will be publicly available to support the differential diagnosis of angioedema. Hoping that I have convinced you the need to report the results of genetic testing for hereditary angioedema in clinicians, I would like to thank you very much for following my speech. Thank you very much.
Thank you very much to all our speakers. And now we have some time for questions for Anastasios and Anete. And I might start, Anete, with you with two fairly quick questions. The first one is, why do you think that HAE with normal C1 inhibitor is characterized by later onset of swelling compared to classical HAE?
Okay, it's not an easy answer, but in factor 12, it's I would say easier to answer because we have also the great participation of the estrogens. So usually puberty usually triggers the symptoms, and the patients also develop after pregnancy. So we have evaluated several patients. As you know, we have a high number of patients in Brazil, and the hormones are the most present trigger in this group. So this is easy. In patients with plasminogen, we can see in the first reports the presence of ACE inhibitor as another trigger factor associated with these patients. So estrogen is not the main one, but it's also present. And as you know, the estrogen affects this mechanism to develop the symptoms. And the last one with vascular endothelium involvement, we have variable onset. As I showed, the last variant presented, the development was of the index patients in late onset, but the children developed very early the symptoms. So it's quite difficult to conclude with so few families reported.
Thank you. And do you think that all the variants respond well to icatibant treatment?
Yeah, we don't have real studies regarding the response to HAE and normal C1, but I have the experience with factor 12. They have a very good response, and it's reported in all the families evaluated. So it could be used as a differential diagnosis, but it's not 100% because we don't have this data. It was a comment by Marc Riedel that we have very few studies about this, the treatment of these patients.
Thank you. We have a question. What approach should we have with patients with HAE, but with high values of D-dimer without signs of DVT? Anete, do you want to comment?
Yeah. It's common to find it.
Yeah.
It's not a good marker. We find it in urticaria and also in angioedema. We know that the dimer could be high, and we have to follow with the diagnosis and treatment of these patients. It was used, there is a publication showing the dimer high in these patients, but it doesn't mean that they have any problems with thrombosis or develop sequela for that.
Yeah, thank you. Now, Anastasios, there is a very long question here for you.
May I add something about the dimers?
Yes.
We have to underline that D-dimers have a very, very, very low specificity. And the specific use for hereditary angioedema is very dangerous.
Yeah.
Very easily someone has elevated D-dimers for any other reason. Sorry.
Yes. This question is for you, Anastasios. Thank you for your talk. My colleague in China has a male patient with recurrent laryngeal edema requiring intubation, presenting rather late at 58 years old, no known family history, and C1 inhibitor and function are normal. I'm not sure about the icatibant response. They sent to a third-party company for whole exome gene panel, and that was performed and showed a VUS in the F12 on exon 3, not the previously reported mutation, and in silico prediction also showed benign nature. My question is, what would be your next step of workup for this patient?
The answer is the problem is very complicated, but the answer is very simple. What the clinicians have to do is to report the variant to ClinGen in order to become useful for the evaluation of this variant in the future. In regard with the variants of F12 gene that are located in other exons, in other areas of the gene other than the exon 9, we have published a meticulous paper, and we have found many of them, at least I think 3 or 4, that are segregated in patients with angioedema. But it's not enough to decide that these are associated with the disease. The clinicians have to know that the pathogenicity of a variant is a very complicated process, requiring many criteria, and especially functional criteria, and not only computational or segregational criteria.
Thank you very much. Well,
may I comment?
Yes, certainly.
Just 1 minute about clinical data. First of all, the patient presented at late onset, so it's the only member of the family affected. And we should look for acquired angioedema in this patient. And besides, we have to remember that the most common is mast cell mediated, and there are 10 to 15% of the patients do not respond to high doses of antihistamine. So I think that we should go back to this patient and check the history and maybe get some results about treating in other ways. Thank you, Connie.
Thank you very much for your comments. And now we come to the end of our webinar. I want to remind you that for CME accreditation, please complete the feedback form to receive your CME points. Our next ACARE appointment is November the 12th at 2 p.m. CET, and it will be on illuminating the significance of pedigrees in HAE diagnosis. And again, should be a very interesting and stimulating discussion. Hopefully, we'll see many of you at the Global Angioedema Forum in Copenhagen coming up very soon in the first week of October. For those that are stimulated to consider becoming a care centre, you can visit the CARE website for all the information, documents that you are required to fill in, and any other information to get you started. For those who like to receive their information by podcast, there is an excellent podcast that's moderated by Dr. Thomas Butgerud, and you can access it through this QR code. It's All Things Angioedema. Newsletter, the LevelUp newsletter is also available to you. If you have something to share, please reach out to Julia Fall to put that in the newsletter. And finally, if you want to stay connected on the socials, please scan this QR code. So with that, I thank our speakers for their wonderful presentations. Thank you all for your active participation and say good afternoon or good night, and hopefully see you in Copenhagen.
Thank you.